Welcome. Amazing, inspiring women that work, experience. It's really very exciting to have them here with us today. But I'd like to really start by highlighting the important and vital role that the lived experience plays for both child protection and in the drug and alcohol sector, and how important it is that we listen to that lived experience to help shape our practice, to inform the ways in which we can do better to support our clients, their families and their children. And so Liz, I'd like to start with you today if I could. Liz is someone who has experienced engagement in treatment and residential rehabilitation treatment in particular. And I just wondered, Liz, what do you feel some of the key factors are that make drug treatment effective for women and women with children from your own experiences?
So I wrote some notes because I do get nervous. But look, one of the, of course, having knowledge of the factors that kind of women come into services with is really important. But for me, something that's just as important is actually an individual approach with the woman sitting in front of you. So services are built around this knowledge and evidence-based stuff, but we are still individuals. And so when you have a woman sitting in front of you, actually hear what she's saying. Like, I find that that's something that was really important to me. Like, I had the staff that heard me were the ones that I was able to hear as well. When I said, well, this isn't working for me, and things were changed a little bit, and this is going back 10 years, so, but having staff with the ability to listen and explore was really important for me, rather than just going, well, this is the program, this is how it is, and you have to follow these rules. Sorry, I'm very nervous.
No, that's totally fine. No, you take your time.
And also as well as that, of course, having staff who have an empathetic and compassionate approach. I find that, and I've worked in drug and alcohol as well, so I've kind of, I've been a consumer, and I've also been a staff member, and I've sat there and kind of watched different interactions between staff members who, have empathy and will sit down and have a conversation and be with the person, and the interactions, staff members who might just be like, do this and do that and follow the rules, and they don't have that level of understanding that actually this woman's come into this service with a whole range of stuff that's gone on in her life, and the things that she might be doing are actually protective factors for her. And so I find it really important that, people have understanding that, maybe, okay, we don't understand, we've never been through this, but I can understand that, this is the things that you do. I guess thinking of women with children, my experience was I was able to have my son come in on weekends to the service that I was in, and that was really important. Really important for me, because then a couple of years later when he came back into my care, I'd had those periods of time where, I'd had him with me, and there was that engagement with support.
Yes.
And what I've seen since then, working in the field, is services actually who work with the children as well as the parents. So not just having them there, but who work with the children as well as the parents.
So they become part of the therapy.
It's, like if their mum is in rehab, they've probably experienced stuff, and they need support too, and there needs to be that kind of support between the mother and child relationship, but also the support for the child as an individual client of the service. And look, something that's been touched on a few times is networking, because networking between services, if a woman comes into the service and is like, well, this isn't the one for me, it's not working, that networking is really important, because I did a really therapy-heavy based rehab, which a lot of women couldn't do. It was intense. It was very intense, and a lot of women couldn't do that, but they may go into that service because they have to get in somewhere really quickly.
Yes.
And if that networking is in place, then what's happening at this service, what program's happening there, and what's the availability. Well, how can we go, okay, this service isn't working for this woman, let's move her into this one and let's maybe provide her with some in-between care if she can't get straight into
really
this one, but
it.
this one's not the right one. You know, it's not that she's not right for the service, it's that the service isn't right for her. Yeah.
And so I suppose following on to that, with your role now, trying to support you know, people with lived experience and to have their voices heard within the organisations. Do you have some hope there that we can do better in that space, that there's opportunities to really grow the opportunities for people to give that feedback and to...
Yes, 100%. I've just started working with a few services, very early days. And I'm actually hearing and feeling so much openness from those services in regards to consumer participation, actually really listening to what we have to say, you know.
Fantastic.
Because, yeah, we know what we need. Sometimes it needs to be explored, but we know what we need.
That's fantastic. Thanks so much, Liz. And it's quite a nice segue, really, to throw to you, Kate. So, you know, we're fortunate in New South Wales to have services specifically for women and in the case of Phoebe House, women and their children or their babies. Can you tell us a little bit, Kate, about Phoebe House, what it offers in terms of that program? Liz has obviously alluded to the fact that, you know, sometimes it can be quite intense, but there's opportunities there to bring the child into the therapy. Can you talk a little bit about the Phoebe House experience?
Suzie, I could talk all day. Sorry, everyone. So Phoebe House is a residential drug and alcohol program for women who are on opiate treatment, so a heroin replacement therapy, and we take children as well, which is sometimes a little bit rare. I know that there's quite a few services in New South Wales that do offer women's and children's beds. Ours is quite specific around that pregnancy and newborn stage, though. So we're targeting the earlier intervention style thing, unfortunately. It's a pity that we have to do that, but that's where we're at. And look, I am fortunate that we actually get to work with Liz in the next few weeks around the consumer engagement. So I'm very, very, very much looking forward to it. And whilst we do have some consumer engagement, I think there's a huge part of the AOD sector that can probably enhance that so much more. So good work, Liz. I'm looking forward to it. In terms of Phoebe House, I could literally talk for a week about what we do. There is so much that we do offer. The same as pretty much every other women's and children's rehabilitation service in New South Wales. So if they don't mind, I will speak on their behalf. Most of us provide counselling, case management, and parenting capacity skills assessments, as well as parenting skills development. Phoebe House is a little bit unique. We have our own early childhood centre where our children get to spend time doing educational, age-appropriate play activities with 2 early childhood educators, whilst our mums participate in counselling, case management and group therapy. So that's probably one unique part of Phoebe House that some other services don't necessarily offer. We have a huge, as do others, huge emphasis on attachment and bonding with mum and baby. So we advocate quite strongly for mums to come in with their children. Sometimes it works, sometimes it doesn't work, and we will put our hand up first and foremost to say this isn't working. I think we need to change the tact here. If you think about it, our clients are both the children and the mum. We don't have that separation where some other services might have only clients or adults as their client. We actually incorporate the children, as Suzie said, and as Liz said, into treatment. We see such huge benefit for mums having their children in their care, so that we can actually support that wraparound service. We can actually see what's going wrong, what is going well, and kind of figure out what we can do differently as we move forward. I will admit sometimes we don't do great jobs, but we do everything we possibly can do in order to make the best choices for our women and our children. Children at the forefront of all of our treatment options, which is certainly something that the sector is, well, our women's sector is moving towards, is having that children as part of our treatment.
So Kate, just before you, just on that, I just want to highlight that point, that you feel like there has been a bit of a shift and change over time and a greater emphasis on bringing that whole unit together, if as you say, it's appropriate?
Yes, definitely. And I think that's part of where the AOD sector can definitely help enhance DCJ's movement. If we're able to listen to each other as staff, as colleagues, then we should be able to have that nice transition well. And look, we're not going to put a child at harm or at risk or anything like that. So if we don't think it's an appropriate move, we will say that's not great. Let's do this instead and move towards that in our future. We understand that the children are definitely vulnerable, as are our women, but we're not going to do anything that puts that child at risk. I've lost my train of thought there. Sorry.
Sorry about that, Kate. I just think it's really interesting and important to think about that possibility of change and adapting. And I suppose, does that also point to the fact that it's useful to engage the child protection workers if, early on in the situation, so that they can see that there's expertise in your area and expertise in theirs and how you can share that?
Yeah, definitely. We, as you said earlier, I think we've got about 95% of our women come with DCJ involvement. So there's always engagement there, which is great. I think part of where we're moving towards is increasing our communication with DCJ caseworkers, DCJ CAP client service managers, which has often been part of the downfall. So it tends to happen in long-term program. We're about 6 to 8 months. So what tends to happen for us is there's some initial engagement around that 1 to 2 month mark. And the DCJ caseworker goes, oh, look, they're settled, they're all good. Kids there, they're safe. Then we don't tend to hear for them for a few months until we get to the end of program.
Right.
And end of program, we go, DCJ, where are you? And all of a sudden they come back in and go, oh, what's been happening? Where are you at? So I think that continued communication is the one thing that we're trying to work on improving as a sector. The one thing I wanted to highlight off the back of what Liz was saying earlier was around that individual care as well. So every single woman that comes into our service is looked at individually. Every child that comes in is looked at individually, and we create a treatment plan and treatment goals that the resident and the child, if they're old enough or if we can help them, they create their own treatment goals, and we work collaboratively with the resident in order to improve themselves.
Fantastic.
We also have a different approach in terms of harm minimisation or safety management, which goes kind of across the whole of our program, which is very different to a few other residential programs. So we tend to work with a woman where if they have used, we don't tend to ask them to leave if they use, which is a tricky, very, very tricky and challenging thing when you've got child protection and child risk issues. We have safety planning and huge amounts of work go into our work with women so that if they do use, then we have child safe, mum safe, and a house that's safe. It's kind of hard for a woman, maybe you can help me, Liz, it's quite hard for any person who's lived in addiction to just stop. So we're fully aware that that's going to be ongoing, and we hope that they don't use when they leave our program, but it's also likely that that will happen. Most people do have a lapse or a relapse when they do leave a program, and it's about setting them up nicely in order for them to make sure that they're taking care of themselves and their child as they move forward.
And I'll just say that was the one thing that I wanted to touch on that I forgot.
No, go ahead.
That's one of the things that I love about the Phoebe House program is that, like, we come into a program having spent 5 years, 10 years, 20 years, sometimes 30 years of using every single day to keep us safe and keep us alive. And it's the thing that causes so much damage, all the stuff that goes on around that, but it's also the stuff that keeps us safe. To go into a program after so much shame and so much stigma and so much punishment for our behaviours, for our coping mechanisms, for the, the things that we use to medicate ourselves, to go in there and to be stigmatised and shamed and punished again is really, it can actually be soul destroying. And it's sometimes, and I've seen women be discharged from a program for using, and the reason she was in that program is because she couldn't stop using. Otherwise she wouldn't need it. They wouldn't exist. You just go, well, you just stop using. You've got kids now, no more of that, and we'd stop, Yeah.
So there needs to be some level of flexibility around that process, and that's certainly something that I benefit from Phoebe House. I'm a harm min girl all through and through, so it's very helpful, but I do recognise that it's very challenging when there are children involved. And certainly something that we have consistent communication with our mums and with DCJ workers about.
Those plans. And I think that, it's also about that flexibility, which is what you're really emphasising. And Margherita, going to a more community-based service and thinking about the counselling that you and your colleagues provide, you often see quite a few women who are from culturally and linguistically diverse backgrounds. Are there things that you feel that you provide that are unique, things that people need to be thinking about in terms of women who may be from a different cultural perspective?
Absolutely. I suppose you could say on any year about 50 to 60% of the clients that come to the centre have a CALD background. Of course, some are rivals, or some are first generation, born in Australia. But I think the thing that is particularly important when you're talking about cultural competence, and we all need to have cultural competence, right?
Yes.
Even with Anglo culture, we need to have cultural competence. And there's probably, I don't know, maybe a few cornerstones to bear in mind. And that's something about actually just knowing that we're different, that there is diversity. And also, what is our attitude? Our own personal attitude makes a big difference towards how we work with diverse communities. I suppose what we need to do to be culturally competent and to provide the best services we can is to actually try and understand what those cultures, what their core values and belief systems are, what makes them them, as opposed to making them somebody else. And I really hold this as a really important thing, because we can't change people, and often we're not the people who change. People can't change to improve their own circumstances, if you like. And we can't facilitate that change if we don't understand who they are and what their barriers are. Oftentimes they feel lost. They might as well be on another planet. People who have come to us and they say, I actually don't know why DCJ are in my life. They just don't actually understand. So we have to spend time doing some psychoeducation around what the system actually is. And we all know that the system, even for Anglo-speaking people, is so hard to navigate.
Yes.
So you can imagine how difficult it is for people who actually, well, might as well be in an alien system. So, and of course, skills. If you are a worker or a counsellor, you actually need to have those skills, and by those skills, I'm talking about trauma-informed care, which for me is probably one of the most important things and that you can do to facilitate change and help people improve their circumstances. People don't respond well, and even if they do respond, they probably don't respond or can't maintain their response over a long period of time unless they feel they're safe, unless they feel that they can trust the person who is working with them, unless they feel that person understands them and can work through things with them, unless actually the change comes from them, not from us imposing something on them. So all this takes time, and one of the reasons our counselling program can last up to, and in fact a little bit over, 2 years of weekly counselling, because the first part of it is actually about establishing a trusting and a safe relationship in which to do the work, in which people can look at. I could just go on and on.
No, please. I think
a breath.
But it's so important what you're saying there, Margherita, about how we do need to take some time. Sometimes we know that our timelines can be different. DCJ may have different timelines to our timelines. And so at the very least, it's showing that empathy, it's providing that education so people at least know what's happening for them. And so lastly, I want to come to you, Sarah, and hopefully if you're online or in the room, I hope you're thinking of your questions for the panel. So Sarah, you've had a lot of experience across different services, both here and overseas. And I wanted to ask you in particular, you know, a lot of clients or women may be directed by DCJ as part of a plan to residential treatment. And in your experience, if that's not quite right fit, is that possible? And what happens there? And sort of what advice would you give to child protection workers about the breadth of treatment options that might be available?
Yeah, it's a great question and an issue or a concern that I've definitely bumped up against throughout my whole career, especially working with women and women with children. I think that DCJ are very well intended when they talk to service providers or to the client and say, yeah, go do this residential rehab or go do this. And DCJ can be very prescriptive in what the client's supposed to do, but they don't have an understanding of drug and alcohol. That's not their expertise. That's not where their expertise lies. And really what Liz said, if I could just quote you, Liz, is when you felt heard, you could really hear. And I think that speaks as well to our relationship with DCJ. We don't feel heard. I imagine you all don't feel heard, so we don't actually even listen to each other. So we're not collaborating. It looks like we're collaborating because we're both doing something with the same client, but the genuine nature and the intention of it isn't there. And I think we AOD workers need to defer to DCJ's expertise, and that needs to be reciprocated as well.
Yeah, so they're really that idea of expertise. And if you're thinking about different treatment options, you know, is it possible perhaps that residential treatment programs and lengthy residential treatment programs are not always the best option for some women?
Absolutely. And what it does, when you immediately default to residential rehab, it gives that client a bad treatment experience. So then when they access another type of treatment, you're already on the back foot. And it's really talking, I mean, I know a lot of services, every service here knows all the services available. It's calling up, you know, Odyssey House and saying, you know, we think residential, but Odyssey House has 4 community programs.
Right.
We might say, no, that person should have a go in community, see how it goes, and if that's unsuccessful, you can always ring us or somewhere else. But it's not an immediate default to residential. It's harmful and it's not helpful at the very least.
And so, you know, there are community options. Obviously, you were talking about that, Margherita, that there's a variety of options, and sometimes it's about, exactly as you're saying, some of that treatment matching, but that can't happen if there's no conversation about that in terms of the planning.
Absolutely, and what we would like to see, if I can speak for everybody in the AOD sector,
please do,
is when DCJ identify a drug and alcohol issue, they ring up an AOD treatment provider and say, this is what I've got. Would you mind doing an assessment and then letting us know what you think? Yeah. So we can work together. Great. And we want to hear your experience and your information. It's often that we don't know DCJ's knowings until, you know, we've had 4 chats, and on the 4th chat we find out, you know, this has happened and that would really impact treatment. And it's really us being on the front foot and having that really rich conversation in the beginning and trusting each other and hearing each other about how we can best work with this client.
And so on that, Sarah, you know, I suppose what makes me think about is that, once again, you know, what Simone was saying too, it's about those building of relationships. And so perhaps, you know, in a way, it's the building of the relationships before the client situation occurs, in a way, so that you know who those contact people might be. And then it's more likely that you might have those conversations early rather than later in the piece.
Absolutely, and I think what Simone said hit the nail on the head. It's not what happens in here, it's what happens tomorrow. Yeah. So I hope from here, I'll give my number to anyone, please ring me, and vice versa. And we really need to have, and it makes by the time we've done 4 clients together, the 4th client's going to be so much easier. Yes. You know, because we just have that relationship, that shared successful experience. And it's genuinely just about us hearing each other. And I really hear what you said. And we can preach that to the clients and the staff all day long, but we also need to hear it as well, as a sector, together. I feel like I'm on my soapbox.
No, I'm loving it. It's good. It's very good. And I'm sure, you know, there's that response too from DCJ workers. So what I'd like to really do now is throw it open to people online and people in the room. What are some of the questions you might have for the panel? Are there things that have sparked your interest? Are there things that you've been thinking about? Perhaps there are ways that you're working right now that are working quite well. So just keep percolating on that. I'm going to come to you in just a minute, so hopefully you've all got your questions ready to go. One of the things I just wanted to pick up again, though, Kate, you were saying that, you know, things might not work. You know, you might have the great intentions in the world, you've got the treatment plan, you think you're going well. But I think what you were saying, though, is that you can shift gears. You can be a bit flexible. You can maybe change the approach. Can you just talk a little bit about how that might happen in reality in your service?
For us, we have constant conversations with our residents. It seems a bit conversational sometimes. I get a bit overwhelmed. But essentially we ask our residents, if we notice that something's not quite working right, there's one actually happening today. They're sitting down with one of the residents who's struggling in the house at the moment, and she's got her newborn with her, and we think she'll do really well if we can manage to get through the mental health issues that's currently presenting, because there's now no drug use. So we're sitting down with her, well, my team is sitting down with her today to have a conversation about what it is that we can change in order to make her experience a little bit more useful for her, what she needs to get out of our expertise or what she needs to get out of our program. For us, it's not just about her attending groups and her doing what she needs to do in order to progress through, but it's also about her developing some insight and her developing some parenting skills and her developing some real understanding of who she is and how she can be and live well in the community. So I guess that will be our conversation with her today around what is it that isn't working for you, what is it that is working for you, and how can we as a team shift in order to make your experience a little bit more nice and actually pleasant, and so that she can get something out of it. And I think those conversations we've been having for a very long time have actually shifted quite a lot of people quite well. Mm-hmm. So we had one earlier this year as well, and it ended up not working, so she no longer wanted to remain at Phoebe House, and that's okay. We're happy to support what she wanted. Fortunately, we had a great DCJ worker at the time who, whilst he was a little bit worried about her going back to community, we actually developed a really good plan, a really nice safety plan for her, and we were able to support her and her newborn out into the community with the assistance
Fantastic.
of DCJ and a whole wraparound service. And I've heard recently that she and her baby are still doing quite well. So that's probably one of the best outcomes we could have had with the DCJ worker going, oh, I'm not so sure about this. And we then had multiple conversations as staff members or as colleagues before we had a conversation with her.
And I think it's a good point too to know that our the drug and alcohol service system itself has changed a lot. We were very fixed, and there are programs that still exist that have a very fixed time frame, but that's really shifted and changed over time, and it's become a lot more, I think, client responsive. And so it's useful, I suppose, for the services to understand that it's not always about locking someone in for a particular time period. The evidence wouldn't necessarily say, yes, certainly engage in treatment, the outcomes are better, but doesn't necessarily mean to be one part of treatment. It's that treatment journey, perhaps. So I'd like to go to the audience now. I'm hoping there might be some questions for our panellists.